Students, so we'll continue with the ketone bodies. Okay, same chemical examination only. So what are the ketone bodies? They're basically acetone, S2-acetic acid, and beta hydroxybutyric acid, right? So these are intermediate products of fat metabolism. All of you know all these things, right? Now, which is the highly volatile part in this three? It's basically acetone. So this acetone is the one that gives the fruity odor in cases of diabetic ketoacidosis. So we will be testing acetone in the urine. Okay, so since acetone is highly volatile, you have to do this test immediately if you're suspecting ketone bodies. Okay, now what a test you will do, it's basically called as Rothera's test. How will you do this test? You'll take 5 ml of urine in a test tube, and to that you will saturate ammonium sulfate. What is this saturate? What does it mean? You're basically adding so much of ammonium sulfate that you will still have some crystals remaining. Okay, that further it cannot be dissolved in that particular solute, right? Then to that, so you mix properly, then to that you will add 1 or 2 crystals of sodium nitroprusside, right? Then gently you tilt the test tube, and towards the side, on the sides, you will gently add liquor ammonia. Okay, so you will get a purple colored ring at the junction between the two. This takes around 30 to 60 seconds. Okay, so now let's see what is the principle behind it. Okay, so sodium nitroprusside, basically that is the compound which you're adding, right? It gets decomposed in an alkaline medium. How does it become an alkaline medium? Because you're adding ammonium sulfate, right? You are saturating that particular urine with ammonium sulfate, so that turns into an alkaline medium, right? So since the byproduct, it becomes is a strong oxidizing agent. Only in the presence of acetone or acetic acid you will have that strong oxidizing agent. Okay, and when you add liquor ammonia along the sides, you will get a purple ring. So this is the principle of Rothera's test. You should know all these things because this is important for Viva as well as for your theory part. Okay, now let's go to the next compound. The next compound is bile salts and bile pigments. Okay, so what are the bile pigments? It is bilirubin, biliverdin, and bilicyanin. Okay, so bilirubin, ideally it is detected in urine only when the quantity is more, when it is more than 0.02 milligrams. Okay, urobilinogen is normally present in urine, but the amount is a little less. It is in small amounts. Okay, bile salts will be present in urine only if there is an obstruction to the bile flow. For example, in cases of gallstones or in cases of any atresia or any obstruction to the bile duct. So in such cases, you will have bile salts in urine. Okay, now let's see how you will detect all these things. First, we'll go to bile pigments. Okay, how will you detect bile pigments is mainly done by Fauchett's test. So for that you require 10 ml of urine and you require 2.5 ml of barium chloride. Okay, mind the spelling, sorry. And then you mix it properly and then you filter it. Okay, to this you will add Fauchett's reagent. What does this Fauchett's reagent contain? It is basically ferric chloride in 2% trichloroacetic acid. Okay, so you just have to add 1 drop of Fauchett's reagent to that particular filter paper. You will get a precipitate. Depending on which bile pigment you have, you will get the color. Okay, so if it is bilirubin, you will get a yellow color. If it is biliverdin, you will get a green color. If it is bilicyanin, you will get a blue color. Ideally, you will get a combination of greenish blue in color. Okay, so just remember these things. These are small things, but it still matters. Okay, now the next let's see the principle. What happens here? So when you're adding when in the presence of bilirubin or bile pigments, you're adding barium sulfate, right? To that, when you're adding Fauchett's reagent, okay, what will happen? You will get a greenish compound. Basically that is the principle behind it, right? Now, the next test is urobilinogen. What is the test you will do for that? At least you should know what is the name of the test. Even if you don't know the principle, you need to know the name. Okay, that is Elix aldehyde test. Okay, so suppose urobilinogen is present in urine in excess amounts, then to that when you add Elix reagent, you will have a pink compound or a pink complex. Okay, that is the aldehyde complex which you're seeing. Okay, so here the procedure is you add 10 ml of urine, to that you'll add 2.5 ml of milliliter of barium chloride. You mix well, the same you filtrate, and to the filtrate you add Elix reagent. Okay, and then you observe it from the top. Okay, so ideally you're supposed to get a pink color that indicates that there is urobilinogen. Right, there are some causes of for false positive. One is porphobilinogen, and then you can have in any forms of indoles or sketoles. These are the conditions where you can get false positive tests. Right. Next, we'll go to the bile salts. So we're done with bile pigments and we'll go to the bile salts. What are the bile salts? You know, it is sodium glycocholate and sodium taurocholate, right? So for the determining the bile salts, the test used is Hayes test. So what you require here for Hayes test is you require small two test tubes. Okay, small two test tubes. One is the test and the other one acts as a control. So for test you will add urine, and that urine should be full. You're adding the test tube up to the brim. Okay, and in the control you will add distilled water or tap water, whatever, up to the brim. So that means the entire tube will be full. Okay, full with urine in case of test and full with distilled water in case of control. Okay, and then you will sprinkle sulfur powder on the surface. Just sprinkle like that on the test tube. Okay, so if bile salts are present, it will sink. So ideally in the test it should sink, right? And in the control it will float. Okay, now why is it sinking? The presence of these bile salts, that is a sodium glycocholate and sodium taurocholate, will reduce the surface tension. Okay, so thereby the sulfur granules or sulfur powder will settle down. Right, fine. There is another chemical examination also. We'll do blood, right, for to detect blood. These are some terms which it's better for you to know. Okay, what is hematuria? Hematuria is nothing but red cells in urine. Hemoglobinuria is free hemoglobin in urine. Okay, suppose the urine is reddish, then what will you do? You will centrifuge the urine. So what happens? RBCs will sediment and you will have the supernatant. Okay, so you can do the test in that supernatant. It is definitely it's not done actually these days, but you should know what it is. Okay, so what is the test done for blood? It is benzidine test. Now how is benzidine test? You're adding basically a combination of benzidine solution and hydrogen peroxide. Okay, so to that you will add 2 ml of urine. If blood is present, you will get a blue color. Okay, so this is not done because benzidine is carcinogenic. Okay, benzidine is carcinogenic, and so hydrogen peroxide is a very unstable compound. You require to prepare fresh solution every now and then. Okay, so that's why it has not been done these days. So just remember, even for viva purposes, they might ask you what is the test you will do for blood to detect blood in urine. Okay, so that is benzidine test. Clear? Right. So now that we have finished physical examination, chemical examination, and now we'll go to microscopic examination. This is actually the crucial part in urine examination. Okay, but you don't have to do this, but you should know what are the substances you will find in urine. Okay, what are the microscopic elements? So as a lab is concerned, this is an important aspect. It is very easy to do and it is easy to miss also. Okay, some of them are very dicey that only trained eyes can pick up these things. Right, now so let's see what will you do with the urine. So we are getting a urine in bottle. Then what do? You add around 10 ml of urine and then you centrifuge it. Okay, you centrifuge it for around 300 rotations per minute. Okay, 300 rotations per minute for around 5 minutes. Then what happens? You will have a supernatant. You will discard that supernatant. Okay, so you have a test tube here. You're filling with urine, and once this is centrifuged, you will have sediment below. Okay, that is a sediment. There you have sediments, right? And this is the supernatant part. So you will discard the supernatant and only the sediment is required for us. Okay, so then you will put a drop of this sediment. This sediment is put on the glass slide. Okay, and then you place a cover slip, right? So you place a cover slip and here you observe it under the microscope, initially in low power, then you go in for a higher power. Right, clear? Now we'll see what are the sediments you will look for. Basically they are classified into two. You have unorganized sediments and organized sediments. So we'll see what are the unorganized ones and then we'll go to the organized ones. So ideally in unorganized you will find crystals. They are seen as crystals. They vary according to the pH of urine. So that in acidic you have some form of crystals, in alkaline you have some form of crystals. Okay, so in normal urine you can have different types of crystals. You will have uric acid crystals, urate crystals, calcium oxalate crystals, phosphates, calcium carbonates, ammonium biurates. All these are crystals, but not normally seen in urine. Not all are normally seen in urine. Okay. Now we'll see what are the crystals which are present in acidic urine. In acidic urine you have uric acid and urate crystals. Okay, why this happens? This is actually quite common and it is usually seen in long standing, when you keep the urine sample for long standing cases. That means if it is not a fresh sample you can have uric acid crystals, or if they're basically amorphous urates, or when you have uric acid, when the patient is excreting uric acid, there also you can have uric acid crystals, right? So how do they appear? They appear as reddish granules and the shape will vary. They're usually yellow stained. Okay, I'll show you the picture. Sorry, that picture is not here. Okay, this is another crystal called as calcium oxalate crystals. So if you can remember, this is envelope shaped. Okay, can you appreciate that envelope shaped? Right, that is envelope shaped. There are other shapes also. You have dumbbell shaped and they have a tendency to clump together. In the previous picture itself, can you see, if you can appreciate that? Sorry, can you see them? They are clumping together. So this clumping gives a tendency of stone formation. So there are more chances the patient develops stones, kidney stones or ureter stones anywhere. Okay, now let's see what are the crystals present in alkaline urine. Okay, so in alkaline urine it is usually the triple phosphate crystals. Why are they called as triple phosphate? They're basically ammonium, magnesium, phosphates. Okay, and they usually coffin lid. Okay, coffin lid, or they can be feathery or they can be leaf like. Okay, so what does this triple phosphate crystals indicate? They are basically indicating that there is stone in either the kidney or anywhere in the urinary tract. It can be the bladder, it can be the ureters. Okay, so how do they appear? They are usually coffin shaped. Can you appreciate that? This is the coffin shaped. All these are triple phosphate crystals. This is a coffin, or it can be a lid, just like a lid, right? Next you have calcium carbonate crystals. Calcium carbonate crystals are colorless and they are spheres, or they can be dumbbell also. Okay, sometimes it is usually mixed, it can be mixed with phosphate deposits. Okay, that is how they usually present. They can have a mixed mix, that is triple phosphate along with that, or it can be just phosphate crystals. So this is your dumbbell shaped, or it can be spheric spheres. Okay, now coming, what are the crystals which are seen in abnormal urine? Okay, we are not supposed to see. When you see them, they are definitely abnormal. They are cysteine, tyrosine, leucine, sulfonamide, ampicillin, and radiographic media, or that is called as meglumine diatrizoate. Okay, these are the crystals present in abnormal urine. Okay, so let's see cystine crystals. They are highly refractile, okay, and they can easily form stones, usually hexagon in shape. See, that is a hexagon shape. Another picture. Then you can have leucine and tyrosine crystals. They usually occur together, okay, and that indicates a severe liver damage. Okay, these are leucine crystals. I mean, a bit oval, and they usually yellow crystals. Tyrosine crystals are needle shaped, fine needle shaped as sheaves, and they have a constriction in between, something like somebody has caught in between. Okay, and it is usually black in color. These are the tyrosine crystals. Then you have sulfur crystals. When you are taking sulfonamides or any form of sulfur drugs, they can be easily visible in urine. Okay, and so that's why history is important for us. Okay, when you asking for when you see any form of crystals which are abnormal in urine, you have to go back and inquire the history. So these are the sulfur crystals, something like a fan shaped, or it can be variable. It can have even a slender or a small square shaped, a variable actually. Now let's go to the organized sediments. So now that we have finished unorganized, you have organized sediments. What are the organized sediments? Main thing is you have casts. Okay, epithelial cells, WBCs, RBCs, spermatozoa in case of males, bacteria and parasites. Okay, so these are the organized elements in urine. So let's see what are the different casts. First caste is a tubular caste. This usually or invariably indicates that there is some form of kidney pathology. How are they seen? They are seen as cylindrical in shape. I'll show you the picture. I think it is there later. Cylindrical in shape. Okay. And why is it? Mainly because of coagulation of proteins. That is called as Stam-Horsfall proteins. Okay, there are different types of cast. I'll show you the picture of tubular. See, this is a picture of tubular cast. See this one, if you can appreciate this. These are all tubular casts. Okay, so that indicates there is some form of chronic kidney disorder. Okay, now the next one is hyaline cast. Okay, hyaline cast, they are nothing but they are transparent. If you can see in this picture, this is urine. Under microscopy, you can see that this is transparent. Okay, and they are soluble in acetic acid. Again, it indicates it's usually seen in patients with kidney disorders. Right, and see, next is granular cast. If you can appreciate the granules which is present, okay, and they will clump together, that's when you form the granular cast. All these are indicating that there is some form of kidney disorder. Okay, so this is also again a coagulation of proteins and with granules embedded. Okay, they can have disintegration of RBCs, or it can be some form of epithelial cells also which is disintegrating. But remember, this is not normally present in a normal urine. It invariably indicates that there is some form of kidney disorder. Okay, so you have, these are epithelial cast. If you can appreciate, these are epithelial cells which are clumped together. Okay, this is also invariably seen in cases of acute renal disorders, and most commonly it is acute tubular necrosis. Okay, right. Now you have RBC cast. This is again RBCs, they are getting stuck together and they form cast. They form these kidney. They have to come through the tubules, right? So that's why these they have this particular shape. And RBC cast are more commonly seen in acute glomerulonephritis, malignant hypertension, Henoch-Schönlein purpura, SLE. All these conditions you will have RBC cast. Okay. So RBC cast, if you can see, it has to remember the nephron, right? So RBCs are usually, they get embedded within the proteins. Okay, so and it is commonly seen in, I told you, acute glomerulonephritis, right? When there is glomerular inflammation, what happens? There is leakage of RBCs, and thus they will form RBC cast. Okay, so these are your RBC cast. Can you appreciate that? Because it has to go through the tubules, it takes that particular shape. Next is pus cell cast. From the name itself, pus cell. So it is some form of infection. It can be acute pyelonephritis, or even in case of acute glomerulonephritis, you can get pus cell cast. Okay, they're nothing but polymorpholeukocytes and some degenerated pus cells which is embedded within the matrix, within the protein matrix. Okay, so this is fatty cast. Fatty cast is invariably or most commonly nothing but fat globules which are getting accumulated there. Okay, and it is most commonly seen in nephrotic syndrome. Okay, so they again, these are numerous fat globules which are stuck to each other. So how will you stain fat? It is mainly used by a special stain called as Sudan black, or you have Sudan 3 stain. Okay, next is the waxy cast. Waxy cast is again, can you see if you can appreciate that transparent structure? That is again a waxy cast. Okay, because usually it is seen in cases of amyloidosis, or in cases of end stage renal disorders, in cases of chronic renal failure. Okay, this is never seen usually in urine. Okay, if you see this, remember this is definitely very pathological. You have to inform the clinician, and you have to tell them that this is definitely requires some form of intervention. Right, and the next other forms are, you have RBC cells. RBCs, if you can appreciate, these are the RBCs, the small ones which you can appreciate, these are the RBCs. Okay, the large ones are the WBCs. Okay, these are all RBCs. The large ones which you're seeing here are the WBCs. These are the WBCs. These are normally present in urine. Okay, WBCs you can get there is 2 to 3 in a field, you can see them. If you find it beyond that, it is definitely indicating that there is some form of urinary tract infection which requires medication. Okay, these are the pus cells. Adjacent to that, if you can appreciate, those are the RBCs. Right, if you can see here, the big ones are the pus cells and the small ones, these are the RBCs. Okay, so that there's an urine indicating that there is some form of definitely there's some form of infection. Okay, next we have squamous epithelial cells. They can be normally present in urine. Okay, so most commonly seen in females. This is another squamous epithelium. Transitional cells can also be there, but this is very rare actually. 1 or 2 if you find, it's fine, but beyond that if you find, it is very pathognomonic of urinary bladder malignancy. Okay, again these are urothelial cells or transitional epithelium. Now bacteria is, if you find bacteria in large numbers, it definitely indicates urinary tract infections. So what do? You can do a gram stain. If in case you're suspecting a TB, you can do even acid fast bacillus staining also. Okay, this is spermatozoa, these ones. Okay, the head and the tail. Okay, usually seen normally you can see in males. Then next you have parasites. You have protozoal parasites. You can even get the ova, you can get the larvae form. Okay, any of these forms you can get. Usually what we say is Trichomonas vaginalis, and in case of ova you can even find schistosomia. Larval forms can be seen in case of helminths. Okay, so this is the Trichomonas vaginalis. These are flagellated parasite. Okay, here all these are Trichomonas vaginalis. This is the egg of a pinworm. Okay, which is stained. Ideally you don't see it like this, but when there was a suspicion, we stained it and we could find the pinworm egg. Okay, so that finishes urine examination, right? Now I will show you what you're supposed to write. 1 minute. So we had stopped here, right? So this is what you're supposed to write. I hope it is visible for you. Sorry. It's okay, I'll take a photo and I'll send it to you guys. This is very small, right? So that finishes the class. Thank you.